Hello, my name is Dr. Christopher Blackwell. I'm an associate professor and the program director for the Adult Gerontology Acute Care Nurse Practitioner programs in the Department of Nursing Practice in the College of Nursing at the University of Central Florida. I'm also an acute care nurse practitioner, and I'd like to welcome you to the first part of a two-part narrated PowerPoint series covering solid organ transplantation. In this particular unit, we will be looking at organ transplantation through the eyes of the liver, because of all transplantations, I don't know, maybe cardiac might be a little bit more complicated, but because of the amount of hematologic involvement and cardiovascular supply of the liver, we really can look at this organ as being one of the major ones in terms of transplantation management, and a lot of the same concepts, I would say the vast majority of the same concepts related to management of liver transplantation in the intensive care unit transfer over to other organ systems and organs as well. So this is our content outline. We're going to talk about selection and care of the donor and the recipient. We're going to talk about common problems such as rejection, infection, and graft versus host disease, and why these things happen in this particular population. And then we're going to end the lecture on pharmacotherapeutics, and we're going to talk in explicit detail about the anti-rejection and immunosuppressants and other types of therapies that we use to help basically combat some of these common problems like rejection and graft versus host disease. So if you've never seen a liver transplant procedure before, which is probably the vast majority of you, this is what it looks like. You can see the actual surgical procedure here of the forceps devices and the actual liver being exposed intraoperatively for excision and then eventually placement into a living recipient, right? And we're going to, like I said before, we're going to present all of the content related to transplantation through the eyes of the liver. We could have an entire course on transplantation of all the various organs, but we don't have that luxury. So we're just going to focus on the liver. So let's talk about how candidates are selected. And you'll see this OLTX abbreviation used throughout the lecture, and that's just basically the abbreviation for orthotopic liver transplantation. And it really is the definitive treatment for patients who are at end stage in terms of liver disease, okay? And luckily for patients that undergo this procedure, the 1-year survival rates are actually pretty good. They're almost 90%. And of course, looking at which candidates are appropriate for this is going to be vital, right? I was at the gym today and I was actually watching a series on Netflix called Ozark, and it was kind of funny because I'm not going to give you any detail about the show, but basically this family is having to get up and relocate to the Ozarks in Missouri, and they're looking for a cheap place to live, and they find this this place to live where the home is nice and the overall price of the home is low, and the caveat of that is that the guy living there who's selling the house is dying. He's in end-stage heart failure, and he's been given, I think, a year to live, and he's 82 years old. And he makes the joke of to the family as they're looking at the house that look, I'm not going to be around much longer because they're not going to give me a heart transplant. I'm 82 years old, and it gives me a little bit of a laugh to hear that, but in actuality that's true. They're not going to give 82-year-olds heart transplants. They're not going to give 82-year-olds liver transplants. So, the optimal candidate is, no matter what it is, if it's liver transplantation, lung transplantation, the optimal candidate is going to be that person for whom that risk of surgery is far outweighed by the potential improvement in quality of life, okay? So the person that's going to be a survivor, that that's going to have long-term, hopefully improved quality of life, but is going to be the lowest risk of surgery that there is. So what type of patient would be at higher risk? Well, certainly the patient that's had a prior right upper quadrant abdominal surgery. And you typically see this, for example, in a patient that's had, for example, prior liver surgery. So maybe they've had a cholecystectomy, or maybe they've had biliary reconstruction surgery, or something that has resulted in, possibly the formation of scar tissue, fibrotic tissue, those types of problems, or they've already got reanastomosized connections down there. And so when we go in to do a surgery on the liver, when we already have anastomotic leftovers, if you will, and procedures that have been done, it's going to be technically more difficult for those people. One of the things that we've learned when we learned in the GI lecture, one of the things that Dr. Guido Sands taught us was the use of the Apache 2 scoring system. And this is a scoring system that we use in the intensive care unit that is a very good predictor of mortality, right? Well, obviously it would make sense that patients who have a high Apache 2 score is going to have a higher risk of mortality. If you have a low Apache 2 score, that means you have a lower critical care mortality risk, and therefore your likelihood of survival after a procedure like this is going to be higher. That makes sense. Patients with cirrhosis and underlying hepatocellular carcinoma, those people are candidates. However, it has to be under certain conditions. So in these people, the disease has to be limited to just the liver, and the lesions have to be small. And there has to be no evidence of major intrahepatic venous invasion and nodal disease, right? So if we break that down further, one lesion of 6.5 centimeters or 3 or fewer nodules, with the largest measuring no more than 4.5 centimeters and a total tumor diameter of 8 centimeters without gross vascular involvement. Why is that? What are we basically saying here? Yes, we're saying that there's no strong evidence of metastatic disease, right? Because if a patient's got mets from the liver, which I can tell you, my grandmother died of liver cancer, and it was very sad. It was a very quick, I don't know if I would say it's quick. It was a very awful death, and she basically metastasized to multiple organs. And I think the very last one that was probably the worst metastasis she had was into the larynx, and she couldn't speak. And she had these gross tumors that grew into her throat, and she had this horrible throat cancer. Well, unfortunately, you can't do a liver transplant in somebody that's got metastatic disease. It's not going to be beneficial to them, right? Patients with biliary tract malignancies, we see this in cholangiocarcinomas. Those have a very high rate of recurrence, okay? So that patient is not going to be a great candidate for liver transplantation either, because when we transplant the liver, that patient is much more likely to have a recurrence of CA. So that person's not going to be a very good candidate for this type of procedure either. So it's very important to review hepatitis, and I can tell you that I am in the process of writing your exam for this particular unit, and you are going to be tested on knowing the types of hepatitis and how to diagnose them, particularly hepatitis B, which we'll talk about in just a second. So remember that there's essentially 5 serosubtypes of hepatitis: A, B, C, D, and E. Remember that, let me get my pointer out here. Okay, so types A and type E are fecal oral, meaning that they come from either contaminated food products, oral sexual activities, or oftentimes what you see in third world countries is you see contaminated water supply, where hepatitis A is actually spread through contaminated water. And the way to remember this is ass to mouth. Okay, I know that's kind of dirty, but it is what it is, ass to mouth. Okay, and unfortunately, you can't with hepatitis E. Hang on one second. The slide timings were on. I didn't realize that. Current slide. Okay, let's go back. Okay, so unfortunately, you can't remember E that way. So the way I always think about with hepatitis E is eating feces. Yuck, vomit, I know, gross. But hepatitis A, ass to mouth. Hepatitis E, eating feces. So these two are fecal oral in their route of transmission. That leaves us with type B, C, and D. Type B comes from body fluids, so semen, serum, all right? Obviously, vaginal fluids would be included in that, but I always think it's easier to remember just semen, serum, body fluids. Note that type D comes from a co-infection with subtype B. So the patient basically is previously infected with type B, and basically there's DNA changes that occur within the virus that result in a type D infection. So what I put in parentheses here is if the patient is vaccinated against type B, then obviously they're also vaccinated against type D, because they can't get D if they don't have B. And then type C is our chronic subtype, right? Chronic hepatitis. Again, body fluids, semen, serum. When I was in nursing school and when I did my first nurse practitioner program, there was no cure for hepatitis C, so it was really thought of as being the death sentence, if you will. But now with Harvoni and some of the other newer, very potent antivirals that exist, we can eradicate hepatitis C in the vast majority of populations. Remember that there is no vaccine for hepatitis C, but there is a vaccine for hepatitis A and hepatitis B. So vaccine preventable hepatitis includes types A, B, and D. Okay, and this little chart here is pretty good. This can be a very confusing topic, and I have to be honest with you, it's one that I've kind of given up on myself. I'm not an expert when it comes to diagnosing hepatitis. I've always found this to be unbelievably confusing, but I can promise you that I have to introduce it to you. I do have to test you on it because this is a very frequently asked question on your board exams. So know this table, okay? This is the interpretation for tests for acute hepatitis B infection. So notice that the labs are your anti-HBC IgM, IgG, your surface antigen, all right, your anti-HBs, and then what the overall interpretation is. And you can see what the different findings are here. So in acute infection, you have a positive IgM, a negative IgG, and a positive surface antigen. So in other words, positive IgM plus positive surface antigen equals acute infection. All right. And then in early acute infection, this IgG here will test negative. So you don't have the actual IgG coming back yet IgM coming back as positive. So the IgM in the early infection remains negative, right? But usually by the time they present to us, they're pretty sick. So you're going to see this first presentation here rather than the second one. If they've got resolved infection, that means they're going to have a positive anti-hepatitis IgG and the anti-HBs, all right? So that's resolved. If they are not infected or they've been vaccinated, then your HBs is going to be positive, but nothing else. Not infected, none of these are going to be positive, but remember, if they've had the vaccine, your anti-HBs is going to be positive. And then if the patient has chronic Hep B infection, that IgG is going to be positive, as is your surface antigen. Okay, so those are all, this is a really good table to remember for judging diagnosis of hepatitis B. I would know it. Again, to me, this has always been unbelievably difficult to learn because these things are just so similar. So unfortunately, I can't tell you I'm an expert on this, but I do have to teach it to you. I do have to test you on it because I promise you will more than likely see a question on your board exam about interpreting diagnostics for hepatitis. So let's talk a little bit about these hepatitis in a little bit more detail, because oftentimes these are the patients that end up needing transfusions of the liver. So hepatitis A is an acute illness that may cause fulminant hepatic failure, but it does not recur after transplantation. In fact, when a patient gets hepatitis A, once they get over the acute illness, if they don't go into fulminant failure, once they get better, then that person will no longer get hepatitis A. They actually develop antibodies and are immune to hepatitis A after that initial infection, and they actually get over it. Recurrence of hepatitis B, once a near universal problem except after transplantation for fulminant hep B, has been greatly reduced, and that's because we treat patients with immunoglobulin, or HBIG. And those are titrated to levels of anti-HBV surface antigen or surface antibody. By the way, that was in this chart, this is surface antibody right here, okay? So keep that in mind. If that helps you to write that out, you can write that out. Let's go back. Okay. And antivirals like tenofovir and entecavir. These are associated with less emergence of drug resistance than lamivudine and adofovir. These are always the most difficult difficult drugs to pronounce, just because of the combination of letters. Remember though, if you see vir, where's another one? I guess there is another one. But if you see vir in a drug name, remember that 9 times out of 10, that's either going to be an antiviral or an antiretroviral. All right, which is this one, by the way. I believe this is an antiretroviral. And I know that tenofovir, we saw tenofovir's on there, so there it is. That's an antiretroviral as well. Active hep B replication documented by the presence of HBV DNA must be suppressed with antivirals before a patient can go into having surgery. That makes sense, right? We wouldn't want to have a patient who has high levels of hepatitis B DNA floating around in the bloodstream to then undergo a transplantation, and then what's going to happen? Yes, the new liver is going to become infected as well. So we've got to get those under control before surgery. Okay, so this is the same slide, except I added the brand names for you, which I should have read to begin with. So Viride, Baraclude, and Hepcera are the brand names of those drugs that I had difficulty pronouncing. Okay, so clinical progression of the transplanted Hep C patient is highly variable and not predictable, and survival after liver transplant is only slightly lower for HIV positive patients. So HIV infection is not a contraindication to being a candidate for liver transplantation. Yes, there are a little bit lower survival rates for those patients, but not very significant. So patients who have a thrombosed portal vein do present a formidable challenge to the surgeon. Patients have to have patency of the superior mesenteric vein. And basically, before you get a transplantation, what they're going to do is they're going to get an ultrasound or an MRI or an angiography procedure that's going to basically show that that superior mesenteric vein is patent. All right? If it is occluded, you're done. That patient is not going to be a candidate for transplantation. Although the portal vein may be anastomosis to the recipient inferior vena cava with a proximal caval ligature placed to sustain flow, mesenteric venous hypertension persists, GI hemorrhage, ascites, and lower extremity edema become the real problems in that situation. So again, you're not going to see patients who don't have that superior mesenteric vein patency as prominent candidates for this type of procedure. Okay, acute liver failure or fulminant liver failure, which we've talked about, kind of interchangeable words there, is basically liver failure that develops with encephalopathy, and that's going to be one of the key things. And that encephalopathy develops in patients without prior liver disease within an 8-week period or less. So if a person has no history that we know of liver problems, and then all of a sudden they develop within 8 weeks encephalopathy in the picture of liver failure, then they are diagnosed with acute liver failure. So that encephalopathic presentation becomes vital in the diagnostic picture, all right? And these patients are deemed critically ill at the time of transplantation. So these patients are going to be in the ICU prior to transplantation, and then of course, because they're so highly unstable, they're going to be in the intensive care unit after the procedure as well. And part of the reason for that is these patients are going to require intensive hemodynamic and neurologic monitoring. We're going to assess intracranial pressure, cerebral blood flow, cardiovascular instability, the presence of dysrhythmias like atrioventricular dysrhythmias, respiratory insufficiency like ALI and ARDS that are common complications with this. All of these things would put them at substantially increased operative risk. So we're going to be in the ICU monitoring these folks very closely, very carefully, both preoperatively and postoperatively, because these patients can develop extensive hemodynamic instability, neurologic instability. We're going to learn about that in just a few minutes, about how we're going to look at cerebral blood flow as a major outcome determinant, and then this cardiovascular and pulmonary instability as well. And there's other organ systems that come into play too, and we'll talk more about those as we progress. But patients often go into renal failure after this procedure, endocrine failure, other issues as well. Okay, common precipitants pushing ESLD patients to need a transplant are going to be things like recurrent infections, so pneumonias, bacterial peritonitis, and then those who have significant GI bleeding. So patients with those esophageal varices or gastric varices, those are very tender varices that tend to rupture and hemorrhage out like you're seeing in this endoscopy picture here. Those patients are going to be definitely at your highest likelihood as being candidates for this. Why? They've got such severe liver failure that they're experiencing severe portal hypertension, and that portal hypertension is resulting in things like gastropathy, bleeding from the esophageal varices, or even varices that have developed into the stomach or into even the duodenum, which can ulcerate, perforate, and cause a significant GI bleed. Age is going to be important. I mentioned that in the joke earlier in the lecture. The presence of steatosis. Steatosis, whenever you think of, or whenever you see the word steatosis, I want you to think malabsorption syndrome, okay? These are people who are not adequately breaking down fats in foods, and so they're passing very frothy, fatty, very foul-smelling stool. Hypernatremia, impaired lidocaine clearance, those have been, those things like advanced age, prior presence of steatosis, hypernatremia, and impaired lidocaine clearance. Those are all associated with poor outcomes after a liver transplantation. Brain death results in marked changes in homeostasis for the donor. Hemodynamic instability is common and may result in part from massive free water deficits, which can be caused by diabetes insipidus. And correction of diabetes insipidus with desmopressin and adequate hemodynamic monitoring and intervention are essential to preserve vital organ function. All right, very important concept there. Despite a report of successful graft function after prolonged cold ischemia, times of up to 24 hours, the best outcome is associated with 6 hours or less of cold ischemia. Donation after cardiac death results in a graft with an additional warm ischemic insult, which is a consequence of the hypotension and hypoxemia that result from withdrawal of hemodynamic and respiratory support. So until death is pronounced and a cannula can be placed to infuse cold preservative solution, this becomes a serious warm ischemic insult problem. Okay, and this is kind of cool. This nurse here is holding a liver that's been removed, or maybe that's a surgeon. I don't know, but that's an actual liver organ there that's been removed. One of the things I can tell you, when I had to work in, when I was in grad school, I had to go through a few weeks with a pathologist, and I remember removing the liver of the corpses that we were doing necropsies on. And one of the things that I remember about the liver is it is huge. It is a very large organ. I couldn't believe when we removed those livers how big they were. I'm like, God, how do people have organs that size inside them? The other thing I remember is it was very heavy. We would put it on the scale to weigh it, and I remember the scale would bounce up and down from the traction of just putting that liver on the scale. So very large organ, very heavy organ, and as we've learned already, very vascular organ, right? But this warm ischemic insult that occurs, from this cardiac death can really cause tissue damage and other problems that we want to avoid. So these patients, when they are pronounced dead, they're going to be continued on respiratory support, hemodynamic support if we can, and basically putting in a cannula and keeping that liver as cold as we can before we go ahead and use it as a graft. So, recipient operation. The surgical procedure may be divided into 3 stages. The first stage is the hepatectomy stage, okay, which is obviously excision of the liver. The anhepatic phase, which obviously is where the liver is now missing because it's been removed. And then the post-reperfusion phase. And we maintain a large bore central venous catheter and the ability to infuse whole blood at rates that are very high. As high, as a matter of fact, as 2 liters per minute using a rapid infusion system. So, like I mentioned before, the liver is so incredibly vascular that this procedure could significantly hinder overall circulatory what's the word I'm looking for here? It could seriously damage all of our organ systems because we rely on that massive amount of vascular supply of the liver to maintain circulation. So when we're removing the liver, we've got to maintain an infusion system that is rapid. So we're talking 2 liters a minute to maintain hemodynamic stability, and obviously, because this is so vascular and connected to such large vessels that have to be disconnected, hemorrhage is a major issue during the surgery. So when the patient starts to hemorrhage, you'll see that intraoperatively they'll actually use one of these rapid infusion systems to maintain both that hemodynamic stability and then also maintain adequate circulation. Right ventricular function may be compromised by the presence of pulmonary hypertension, which is a complication that develops sometimes during the acute reperfusion process. So, right ventricular ejection fraction and end diastolic volume are much more sensitive guides to cardiac preload than our central venous and pulmonary artery occlusion pressures. So, this is not going to be, something that we're going to get from the Swann's catheter reading. The patient might have a Swann's catheter, and we would want to look at central venous pressure. We would really want to look at right ventricular ejection fraction and end diastolic volume as our guides to cardiac preload, okay? These values may be obtained obviously by use of an oximetric pulmonary artery with rapid response thermistor catheter, or again, like we said, the patient might have a Swann's gans, but more than likely not. However, more robust cardiovascular assessment is provided using an intraoperative transesophageal echocardiogram. So that is common in liver transplantation. They'll actually have a continuous intraoperative transesophageal echocardiogram going where we can monitor that right ventricular ejection fraction essentially at all times, all right? Because if that right ventricular becomes compromised, then we could have a serious problem, right? We learned already that patients who present with massive PE, for example, what happens? They blow out the right ventricle. Once you blow out the right ventricle, guys, you're dead. There's nothing we can do for them at that point. So all of a sudden they've gone from needing a liver transplant to a heart transplant, right? All in the same setting. Congratulations. You're getting a 2-for-1. No, I'm just kidding. Obviously, they would never get a 2-for-1. Okay. Although cerebral blood flow measurement in the operating room is difficult, we do use transcranial Doppler studies to look at this. They also do studies of the arterial jugular venous oxygen content difference to look at the overall balance between oxygen supply and demand. And this measurement assesses the difference between basically the O2 content of the arterial blood versus the venous blood. And that gives us a proxy value for the amount of O2 consumption that's going on. And cerebral blood flow also may be assessed using that transcranial Doppler ultrasound to measure the velocity of flow in the middle cerebral artery. All right, and we're going to learn in the next lecture for Unit 6 just why that is such an important thing. One of the things that we use to confirm brain death in individuals is exactly what I just said. We'll actually do a transcranial Doppler to measure velocity flow through that middle cerebral artery, which is non-existent when the patient is dead. All right, so again, cerebral blood flow is going to be very, very important during this procedure because we don't want the patient to stroke out because we've removed a very vital component to the cardiovascular system. A rapid sequence induction of anesthesia is indicated as gastric motility is impaired in patients with cirrhosis, and the procedure may be performed before an adequate period of fasting. So what you'll oftentimes see for anesthesia use is propofol, fentanyl, and succinylcholine. And then they'll actually induce the patient with that and then maintain them through the procedure using a balanced technique of volatile anesthetics like isoflurane, muscle relaxation like with vicuronium, and judicious use of narcotics like fentanyl and benzos like Versed or midazolam. All right, so this is going to be a very, obviously, think about this, unbelievably invasive procedure, so we're going to want to keep the patient under extreme anesthesia. Standard measures of coagulation like PTT and platelet count are very sensitive. However, attempts to correct the values result in excessive transfusion of blood products. So therefore, you've got to not go by the lab, but instead go by some of the other things like your hemodynamic presentations and the hemorrhagic state of the patient. So the surgical procedure involves meticulous dissection, which is often hampered by severe portal hypertension and substantial bleeding from the venous collaterals. And obviously, if we don't sufficiently control the hemorrhage that's associated with this procedure, then we're going to have significant blood loss. We're going to reduce cerebral brain perfusion and flow and give them a stroke, and we're going to cause lots of other problems like hemodynamic instability and other issues as well. Preservation of blood flow in the inferior vena cava, which we call caval preservation, with or without portal drainage, is an alternative technique, also known as a piggyback procedure, and we use that procedure when there's marked hemodynamic instability. Reperfusion is accompanied by cardiovascular collapse in a small and decreasing number of patients, around 2 to 5%. Volume resuscitation, sodium bicarb or THAM, THAM, for correction of metabolic acidosis, calcium chloride, and inotropic support with epinephrine are usually sufficient to restore the hemodynamic stability of patients who are undergoing this procedure. Interesting, I wasn't that familiar with THAM or THAM, and your book mentions it, so I did a little research on it. THAM is no longer available in the United States, so it is not a product that we use in the US. Okay, post-op management. This is for liver allograft function. Early graft function is usually assessed by measuring circulating concentrations of total bilirubin, amniotransferase, canicular enzymes, and clotting factors. And this is basically the classification of graft function that we use after liver transplantation. So we use it in a grade 1, a grade 2, a grade 3, and a final grade 4, okay? And you can see that one of the most sensitive measurements that we're going to see here is going to be your AST, okay? Your ALT only comes into play in grade 2. Your PT, which starts to prolong at grade 2. And then your bile. And the bile in grade 1 is greater than 40, and then finally it lessens to less than 40 in grade 2. It becomes minimal in grade 3 with none in grade 4, which would be a grave sign, obviously, for us. Typically elevated liver function tests when we're looking at, for example, serum bilirubin levels during the first few days after transplant, they're going to reflect that preoperative values and the consequences of procurement. In the absence of severe procurement injury, which is what we're hoping for, that serum total bilirubin should fall to normal within a week. So if the bilirubin is remaining elevated for a week after the procedure, it's not a good sign. An injury pattern is evidenced by an elevated serum amniotransferase levels. All right, so just like we looked at before, so that AST and the ALT, those are going to peak in about 3 days, but they should start returning back towards the normal lab parameters after 3 days, all right? So if we have persistently elevated AST and ALT after the 3 days post-op period, this is going to be a problem. This indicates that there's an injury pattern here. There's a possible injury that's occurred to the liver during the procedure. Canicular enzymes, so these typically rise to 4 or 5 times normal, but then they start to return back to the normal lab parameter within a few weeks. So those ones are going to stay elevated the longest. If the liver was injured during procurement, then the biochemical changes are greater and they last longer. Unless the liver is irreversibly damaged, synthetic function normalizes after the 3rd day and the AKBR returns towards 1. Okay? So again, that is something else that is a good indicator of how well the patient is functioning status post procedure. Okay, so that's another very sensitive lab value that we can look at. All right. Okay. Primary non-function is liver allograft failure manifested as jaundice, coagulopathy, and your encephalopathy. So like we mentioned before, encephalopathy being unbelievably important to the diagnosis, well then, obviously it's going to be a very good indicator post-operatively for this as well. And by the way, that AKBR stands for arterial ketone body ratio, and your book probably says that, but I just want to make sure you knew that. Okay, technical problems should always be considered before an immunologic mechanism is implicated. In other words, we don't want to just go ahead and jump to the conclusion that this is rejection, because we want to make sure that the technical problems like, for example, hemorrhaging, coagulopathy, those types of things are addressed rather than just throwing a pharmaceutical at it and thinking, oh, this is just rejection, all right? Because if we don't recognize a technical problem and then we treat it as rejection, what we get is an intensified immunosuppression reaction, and then that is going to then put that early post-op patient at extreme risk for infectious complication, all right? So again, rule out everything else before jumping to the conclusion that this is rejection. The diagnostic workup for a patient with liver function abnormalities in the perioperative period is going to include a Doppler ultrasound, all right? And the real purpose of doing that liver ultrasound is going to make sure that all the vessels that have been anastomosed during the procedure are in fact patent and that flow through those are good, right? If we don't have good flow through the liver, obviously it's going to put the patient in liver shock. They're going to have transaminitis, and that has to be corrected before anything else can move forward. If we do have, from that basic Doppler ultrasound, concern that there is patency issues, then the patient's going to go for an angiogram or an MRA. Early hepatic artery thrombosis may present as a precipitous deterioration in hemodynamics, abrupt development of ARDS, severe coagulopathy, and markedly elevated serum aminotransferase concentrations, and bacteremia becomes very common. All right? Remember, the liver is one of the most vital filtering organs in the body. It is our blood filter. If we don't have a functioning liver, then we can't get rid of bacteria. We can't get rid of cells like phagocytized cells, for example, from the immune system. Where does that bacteria go? It dumps back into the bloodstream. The patient becomes septic. They develop these types of problems. So again, you've got to be, as the acute care nurse practitioner in the ICU, managing a patient post-operatively, we've got to look out for these types of symptoms very early. And we have to say, okay, this is not sepsis. This is something like, in this example, artery thrombosis. The presentation of portal venous thrombosis is usually much less dramatic, so unlike what we saw with the hepatic artery, the venous thrombosis is going to be in the early post-op period, frequently manifested as persistent ascites, all right? And I got one of the most wicked pictures I could find of ascites for you here, all right? Stenosis at the upper anastomosis presents findings similar to those that occur in Budd-Chiari syndrome. And this is an occlusion of the hepatic veins that drain the liver, all right? And the common presentation that you get in Budd-Chiari syndrome is abdominal pain, ascites, and hepatomegaly. Sorry for the typo there. Let me fix that. There we go. hepatomegaly, okay? So that's what you're going to see. If you're looking more at a venous issue, then it's going to be this persistent ascites, right? Yeah, the ascites is serious. Obviously, this has to be fixed, but it's nothing like the problem you're going to see with an arterial thrombosis where the patient presents in what looks like, MODS, basically, all right? Okay, the diagnosis may be suggested by ultrasound examination, but more commonly, the clinical picture prompts measurements of IVC pressures above and below the anastomosis site using fluoroscopically guided catheters. And when strictures are diagnosed, treatment is commonly surgical, but balloon dilation can, in some cases, fix the issue, and patency of the biliary tract should be confirmed using cholangiography, which is simple when a T-tube or cystic duct tube stents the anastomosis. All right. Okay, so allograft function. Continuing on here a little bit more with our allograft function, but in terms of the humoral component of rejection. So remember that there is cellular immunity and there's humoral immunity. Humoral immunity being that more generalized immunity, and then cellular immunity being antigenic driven and cellular specific. Okay, so humoral components of rejection are evidenced by antibody deposition in the arterial endothelium and by persistence or recrudescence of a positive cross match. Baby, can you let Gabby out? She's at the door needing to go potty, please. The histologic criterion for the diagnosis of ACR presents within the first few days to weeks that are post-op in a periductal lymphocytic infiltrate associated with a cellular infiltrate around the central veins. And rejection is typically associated with a rise in the serum total bili concentration associated with elevations in the circulating levels of amniotransferases and canalicular enzymes. Other findings that you're going to see clinically are going to be, like I said before, things related to sepsis. You're also going to see diarrhea, suddenly increasing ascites, eosinophilia, thrombocytopenia, and laboratory evidence of hemolysis. Okay, I'm not going to test you on these real specific things like this ACR, but you do need to know what to look for post-operatively in these patients that could indicate to you that either there's rejection occurring or that there's some type of technical problem that's occurred with the procedure. A post-op immunosuppression prophylaxis is achieved by administering a combination of corticosteroids and cyclosporine, so Neorol, which is the brand name of that, or tacrolimus or Prograf. Imuron is another post-operative immunosuppression that's used before the advent of the newer agents that we use now, but it's reserved still for patients who have recurrent rejection episodes or for those that for whatever reason can't tolerate drugs like Neorol or Prograf, all right? Cellcept is more expensive than Imuron and has GI side effects, especially diarrhea, but it's less toxic to the bone marrow, so that's at least a plus. Combined tacrolimus, prednisone, and Cellcept is no more toxic than tacrolimus and prednisone, and that three-drug cocktail may actually facilitate the ability of you to reduce the tacrolimus dose. Now, unless you're working in surgery and doing surgical care, you're probably not going to be adjusting these doses too frequently, but it is something that you need to just be aware of. Calcineurin inhibition with tacrolimus or cyclosporine is the cornerstone of treatment. Corticosteroids are administered intraoperatively and throughout the early post-op period. Thymoglobulin and interleukin-2 receptor antagonists may also be used for induction of immunosuppression, which allows for delayed introduction of calcineurin inhibitors, or that tacrolimus. And it also allows for a more rapid steroid taper. That's really good in patients who have renal impairment at the time of liver transplantation who may not be able to have all of these drugs on board because they can't renally clear them. Liver biopsy may be driven by clinical changes or by protocol on day 7. So the patient's not clinically improving, laboratory assays are showing they're not improving, then they might need a liver biopsy. And mild rejection requires no specific treatment other than up titration of the tacrolimus, okay, or the cyclosporin. So that really is going to be the specific treatment for most of this. It's not going to really be adding other agents, but more upping the titration of what we're already giving. Moderate to severe rejection is treated initially with corticosteroids, so we might give a gram of methylprednisolone administered over a 4-day period. So day 0, they get 500 milligrams, day 2, 250 milligrams, day 4, another 250 milligrams. So we're giving them a 500 milligram bolus essentially, then followed by 250 milligrams and another 250 milligrams. A follow-up liver biopsy is performed on the 5th day in patients who have moderate to severe rejection. If rejection persists, then we have to up that steroid. So we're going to give them 2 grams of methylprednisolone over a 4-day period. We're doubling what we gave before. So we're giving 1,000 milligrams, 500 milligrams, and then another 500 milligrams. If the patient has persistent rejection, meaning they are steroid resistant, it's only less than about 5% who will actually develop this, but in those patients we have to treat them with thymoglobulin because we can't use OKT3 anymore. It's no longer available, too toxic. The major adverse effects associated with cyclosporine and tacrolimus are going to be very similar, and those are basically nephrotoxicity and neurotoxicity. Hyperbilirubinemia can occur in patients with sepsis and is known as cholestasis lenta. Okay, cholestasis lenta. Let me see if I've got. Okay, I thought I had some notes on this. I think I must have added it here to the slide. Jaundice may occur with the development of pneumonia or may herald the presence of an abscess, and then other systemic processes such as disseminated fungal infections. Yes, unfortunately, fungal infections can be very serious, very life-threatening to patients who are post-op from transplantation. Viral infections as well, CMV, especially in the liver, herpes, both simplex and zoster, those can ultimately result in complete dysfunction of the liver and ultimately a very poor outcome. Another systemic process that occurs is lymphoma, all right? Non-Hodgkin's lymphoma can develop after solid organ transplantation. We call these PTLDs. And this, what you're seeing to the right is an actual, I think it's a PET study, a PET study if I'm not mistaken. Yes, it is. Positron emission tomography, a scan of the PTLD patient. So this was a patient that underwent a lung transplantation for cystic fibrosis and then unfortunately as a consequence developed PTLD or post-transplant lymphoproliferative disease. And the reason why these patients get this is essentially because we suppress the T cell function, and that we're going to learn that when we learn about agent-specific immunosuppression in the second part of the lecture. Most of these agents work by suppressing T cell immunity, and we know that T cell is cellular specific immunity, and when we suppress that, you get things like cancers, Epstein-Barr virus, those things that normally would be caught through that T cell immunity or cellular immunity, all of a sudden they don't get caught. So you get development of lymphoma, all right? In this particular picture, the arrows indicate opacification of the right and left sphenoid sinuses. That is FDG avid, which is the black arrows. FDG avidity in the right vocalis muscle, which is the blue arrow, and a 2.2 by 1.9 centimeter FDG avid lung nodule. And you can see that on the right picture with the green arrow. All right. And there's scattered foci throughout the abdomen and increased FDG uptake that corresponds into the loop of bowel as well, which is the red arrows. So unfortunately, PET scans basically involved uptake of glucose. They give a glucose injection, and then these tumorous, cancerous areas will have rapid uptake of the glucose, and that's what highlights on a PET scan. So obviously, unfortunately, here what we're seeing is significant metastasis of non-Hodgkin's lymphoma secondary to severe immunosuppression that we get when we treat these patients. Unfortunately, guys, this patient probably is going to die once it's reached levels that are both above and beyond the diaphragm, right? That's how we stage lymphoma, if you remember correctly. Hemodynamic changes. A vasodilated hyperdynamic state is typical of liver failure and rarely normalizes immediately post-op, but patients who are unable to mount a hyperdynamic response do fare worse. And some recipients have pre-existing cardiac dysfunction due to ischemic damage or restrictive cardiomyopathy secondary to amyloidosis or hemochromatosis, and these patients are unable to increase their stroke volume and cardiac output in response to vasodilation. So those patients are going to be the ones that are going to not fare as well. Elevated central venous pressures are transmitted to the hepatic vein and through the liver. Okay? So again, all of these things are going to result in poor outcomes. Hepatic congestion results in impaired clearance of bacteria, endotoxins, and cytokines. Elevated hepatic venous pressures are reflected in elevated portal pressures, which increase bacterial translocation and endotoxemia, further compromising graft function. Resuscitation must be guided by measurement of CVP. In the distributive shock of liver failure, as in septic shock, norepinephrine or Levophed restores regional blood flow more effectively than dopamine. So in other words, in the patient who is post-op liver transplant who goes into distributive shock, we're going to be treating them with Levophed rather than dopamine as our pressor. Low-dose vasopressin or argipressin effectively restores perfusion pressures in patients with liver failure. However, this drug reduces portal flow and hence hepatic perfusion, and these effects obviously might be undesirable in someone who's a transplant recipient. Cardiac tamponade should be considered in the differential diagnosis of low cardiac output associated with high filling pressures. When tamponade develops in the setting of a hyperdynamic and vasodilated state, cardiac output, calculated systemic vascular resistance, and arterial venous oxygen content difference all may be deceptively normal. All right, so cardiac tamponade has to be on the back burner in these patients when they're developing hemodynamic instability. All right, so keep that in mind. Post-op hypertension commonly reflects inadequate analgesia or sedation, impaired gas exchange, or hypoglycemia. Attention should also focus on the toxic effects of cyclosporine. Antihypertensive therapy should be initiated when the systolic pressure is greater than $160 or the diastolic pressure is greater than 95. And we use a combination of alpha and beta blockade in these patients with labetalol or propranolol. Long-term management rests on the combination of beta and alpha adrenergic blockade and the addition of calcium channel blockers as well. ACE inhibitors can complicate hyperkalemia, so we would avoid those for the most part. Hypertension resistant to the first-line agents is usually managed in the ICU with drugs like nicardipine or nitroprusside, perhaps in combination with an alpha adrenergic blocking agent. Pulmonary considerations: atelectasis, pleural effusion, reduced functional residual capacity, and limited vital capacity due to ascites and chest wall edema are often problems. Pulmonary infiltrates in patients with liver disease warrant very serious and immediate evaluation because they could be representative of severe pulmonary edema resulting from left atrial hypertension or volume overload, or ALI and ARDS, which I mentioned earlier. And ARDS usually heralds infection, so commonly it's going to be from an intra-abdominal or surgical site with a secondary peritonitis. Pancreatitis or liver allograft failure, whether caused by rejection, primary non-function, or vascular catastrophes like hepatic artery thrombosis, can also lead to the development of ARDS. So bronchoalveolar lavage, or BAL, is performed with quantitative cultures obtained in the presence of bacteria more than 100,000 colonies, considered diagnostic for pneumonia. Ventilation perfusion mismatching does not constitute a true right-to-left shunt, which explains the observation that hyperoxia results from prolonged exposure to high FiO2. So the most useful preoperative test is the bubble study, or the contrast echocardiography. So little tiny air bubbles are basically used as the contrast agent in these particular types of studies. Normally there's no contrast agent which appears on the left side of the heart after a venous injection of the bubbles. If they appear, then we know that there's intracardiac shunting going on. So there might be a patent foramen ovale. Contrast agent that appears later suggests intrapulmonary shunting. Okay, so again, that would be problematic. Hypoxia usually resolves within the first month, but sometimes resolution is delayed for as long as a year after transplantation. But patients who fail to improve should at that point be assessed for pulmonary embolism. Okay. Secondary causes of pulmonary hypertension, particularly left ventricular failure, left to right intracardiac shunting with increased cardiac output, autoimmune disease, and pulmonary embolism should all be eliminated from consideration, and both portal and pulmonary hypertension confirmed for the diagnosis of portal pulmonary hypertension to be established. Portal hypertension can be diagnosed on the grounds clinically by things like varices, splenomegaly, hepatic vein catheterization, pressure management, wedge pressure, for example, the latter being an estimate of pre-sinusoidal portal pressure. Echocardiography allows estimation of pulmonary pressures by measuring regurgitant flow velocity through the tricuspid valve. However, confirmation with pulmonary artery catheterization is necessary. Inhaled nitric oxide ameliorates pulmonary hypertension and improves atrial oxygenation in some patients. The goal of treatment with epoprostenol is a systolic pulmonary artery pressure less than 60, low CVP, elevated cardiac output, and a normal response to fluid challenge. So a slight increase in PAP, CVP, and right ventricular end diastolic volume, and a large increase in cardiac output. That's what you should see if you have to treat the patient with epoprostenol. All right. Some pulmonary hypertension patients appear to have two concomitant independent processes, both primary pulmonary hypertension and portal hypertension. So consequently, these patients are at risk for increased PAP and right ventricular failure despite a successful liver transplant. Careful monitoring with a PA catheter and echocardiography is essential. Most transplant recipients with severe pulmonary hypertension do in fact die of right-sided failure during reperfusion. So they blow out that right ventricle. They end up dying in the early recovery phase as a consequence of this. This is what I mentioned earlier of why it's so incredibly important to monitor your right-sided pressures in these post-op patients who are status post-liver transplant. Right ventricular overload and failure develop abruptly, compromising the viability of the graft. So you basically end up blowing out the graft as a result of hepatic and mesenteric congestion. Low cardiac output and hypotension results in graft ischemia. So we might treat patients with Revatio, which is a PDE5 inhibitor. Viagra is also what that is, sildenafil, which lowers PAP and may be used alone or in conjunction with prostaglandins and even endothelin inhibitors. So we learned about these drugs in critical care pharmacology, and now you're seeing how they're actually applied in this example in the post-op liver transplant patient. Respiratory failure can be precipitated by volume overload and pulmonary edema, infection, or profound muscle weakness. The increased risk of ALI and ARDS warrants mechanical ventilation with a low tidal volume strategy determined by height-based calculation of ideal body weight. We already know we use ideal body weight as when we determine our vent settings anyway. Respiratory failure can be precipitated by volume overload and pulmonary edema, infection, or profound muscle weakness. The increased risk of ALI, ARDS warrants, again, mechanical ventilation, like we mentioned before, using that low tidal volume strategy, and early extubation, extubation post-operatively, less than 6 hours, is our goal. Of course, that's the goal with everybody, but I guess there must be some research that shows in your liver transplant folks, getting them off the vent within 6 hours is vital. Other things, renal considerations, liver dysfunction and malnutrition make elevations in blood urea nitrogen and creatinine concentration unimpressive, despite a significant decrease in the GFR. So pre-op renal failure basically presages post-op renal failure and results in decreased survival. In the post-transplant period, there are several factors that conspire to impair renal function, and one of the things that these patients can develop is hepatorenal syndrome, which is basically preoperative renal failure resulting in this. Episodic arterial hypotension resulting in tubular damage. Medications can lead to this, like cyclosporine, tacrolimus, and vasopressors that cause renal arterial vasoconstriction. Amphotericin or amphotericin, which is an antifungal agent, which we would treat in a patient who develops a fungal infection, can also cause intrinsic renal failure from tubal damage as well. GI considerations, enteronutrition may be initiated or restarted within 6 hours after transplant, and reanastomosis of the divided portions of the common bile duct post-op in liver patients is what this term here means, basically, okay? So as long as they've had that, we can give them enteral food within 6 hours. Further delay up to 72 hours is required, though, if they've had an anastomosis of the common bile duct to the jejunum, which is this word, or reanastomosis of bleeding sections of the jejunum, which is this word. To resume full dose enteronutrition, although slower rates are often tolerated. Upper GI bleed in liver transplants is uncommon, but prompt investigation is mandatory when it occurs. Things that can often be the cause can include things like gastritis or ulcer development. Sorry about the pause there. A recurrence of esophageal varices and obviously gastric varices can cause bleeding from the GI tract. But bleeding from the GI tract weeks or months after surgery should be clues to you that the patient probably has infection. So this could be something like CMV or C. diff. 5% or less might even have clinically significant pancreatitis. Neurologic changes in mental status. So we talked about how tacrolimus, for example, and cyclosporine both can be nephrotoxic and neurotoxic. But changes in mental status require a thorough evaluation. So most commonly, those adverse effects that we talked about are going to resolve within 7 to 10 days of lower levels. But focal deficit should be the thing that makes you think, oh crap, this patient probably has had either a stroke during the procedure, some type of embolic reaction, or a hemorrhagic complication. Intracranial infection is rare in the early post-op period, but should be considered if the patient has severe headache or develops a new onset confusion. And fentanyl for pain and propofol for sedation are ideal. Why? Yes, because they have short half-lives, we can get them out of the system pretty quickly. The seizure threshold is lowered by several medications used in the liver transplant recipient, including cyclosporine, tacrolimus, thymoglobulin, and antipsychotics. Propofol can cause less hypotension than pentobarbital and can be titrated to burst suppression of 5 to 10 seconds. Patients in grade 3 and grade 4 coma should have ICP monitoring at all times. An elevated ICP with increased CBF responds to hyperventilation, reduction in intravascular volume, and hypothermia. So this might actually be an example of where you see a patient actually being hyperventilated on the vent. Intracranial hypertension with low cerebral blood flow must be treated by increasing cerebral perfusion, pressure by increasing mean arterial pressure. So we use osmotic agents to do this. So things like mannitol or maybe even hypertonic saline, which is actually more beneficial is also, those things are going to be appropriate at this stage. Diuretics, continually replacing the renal system through continual dialysis to minimize elevations in CVP also might be done. Predisposing factors to neuromuscular disorders include patient acuity post-op as judged by the Apache 2 score, poor liver allograft function at 1 week, a requirement for renal replacement therapy, and needing higher dose corticosteroid therapy. Infectious complications in the early post-op period, bacterial and fungal infections are common. The most frequently involved areas are going to be at the operative site and in the lungs. Patients requiring a prolonged, difficult surgical procedure or multiple transfusions of blood, obviously, guys, they are going to be at higher risk for infection. Remember, we learned that the number one cause of death in patients who undergo transfusion is antigenic infection from blood products. But these products can also cause fungal infections. Good girl, Gabby. As are patients undergoing retransplantation. Those are going to be prolonged issues as well, okay? Hang on just 1 second, guys. Okay, sorry about that. I'm dealing with a dog issue here. I'm trying to record this lecture. Okay, so aspergillus is an issue that I mentioned before as a problem for liver transplant recipients. But good thing is we have some newer agents that have shown to be very promising in reducing the fatalities associated with this. So one of the drugs is VFend, and there's also liposomal forms of amphotericin, and the brand name of that is Ambisome. All right. Patients at highest risk for developing CMV are those who are seronegative before the transplant and received an organ from a seropositive donor. Now, the thing is, the vast majority of us are CMV positive. CMV is probably one of the most common sexually transmitted infections in all of humans, and you get it from saliva. It's actually one of the only STIs that you can get from kissing. Most of us, vast majority of us, are carriers of it. Not a big deal for the vast majority of us, but when you wipe out our immune system, then this is what happens. You get an overwhelming CMV infection, which causes severe liver failure. And I'll tell you that one of the worst cases of liver death I've ever seen resulted from an overwhelming CMV infection that occurred in a woman that was getting chemotherapy who just went into this horrific fulminant liver failure. And one of the things I'll remember about her, I may have told you this story before, is that when I actually palpated her liver, yellow discharge came from the eyes. It was the most disgusting thing I think I've ever seen. Obviously, she was unbelievably icteric. And when like I said, when I was going to assess for hepatojugular reflux, I wanted to see if when I pushed on the liver, she got that jugular engorgement, which is common with portal hypertension and right-sided heart failure. Well, when I did it and I looked at the head, that's when I noticed this yellow, nasty discharge come out of her eyes, and it was like, oh my God, I can't believe that just happened. But CMV viremia can be detected by PCR or by CMV assays using the PP65 antigen, and we will treat it with Zergan and Valsite sparingly. Hyperglycemia with endocrine considerations is very common in the early post-op period, and that's because of both the surgical stress and the corticosteroid issues. Also, tacrolimus is known to draw up the blood sugar, so that is known to cause hyperglycemia. And in these patients, we do want more tighter glycemic control, keeping the sugar around 90 to 120, because we know that if we're not careful in these folks, if they're hyperglycemic severely, then they're not going to heal appropriately. We learned how that plays a role in when we talked about HHS and DKA earlier in the semester. Both primary and secondary adrenal insufficiency may be unmasked by stressors such as infection, graft dysfunction, pancreatitis, or bleeding. So measurement of baseline serum ACTH and cortisol levels and subsequent response of serum cortisol to concentropin, or concentropin, I should say, allow recognition of adrenal insufficiency and classification. Thyroid dysfunction, particularly hypothyroidism, is common in patients with primary biliary cirrhosis and in autoimmune hepatitis, and this can be heralded by changes in mentation. And oftentimes we mistake that to be an attribute to a precipitating stressor, when really it's the result of this biliary cirrhosis and autoimmune hepatitis. All right, guys, thank you very much for your patience and your attention. I know that was a lot of very important content regarding solid organ transplantation. Please access the second part of this narrated PowerPoint series to get the rest of this particular Unit 5 for AGACNP 3. Again, my name is Dr. Christopher Blackwell, Associate Professor, Acute Care Nurse Practitioner, and Program Director with the AGACNP programs here in the Department of Nursing Practice and the College of Nursing at UCF. Hope you have a great day. Bye-bye now.